Welcome back to Clot Conversations, the podcast where we dive deep into the world of thrombosis. I'm David Airdrie, Executive Director of Thrombosis Canada, and I'm thrilled to be joined once again by our fantastic co-hosts, Dr. Maha Othman from Queen's University and Dr. Jamil Abdulrahman from Toronto General Hospital. Get ready for a fascinating episode packed with expert insight. Thanks for tuning in.
In this episode, we'll be discussing a paper from the Canadian Journal of Neurological Sciences entitled Canadian Stroke Best Practice Recommendations, 7th edition, Cerebral Venous Thrombosis 2024. We're pleased to have two of the authors join us today, Dr. Thalia Field and Dr. Jennifer Mandzia.
Dr. Thalia Field is a stroke neurologist and clinician researcher at the University of British Columbia in Vancouver, Canada, where she is an associate professor and holds Sutter Family Heart and Stroke Professorship of Stroke Research, focusing on clinical trials and stroke in younger adults with a focus on cerebral venous thrombosis and congenital heart disease. She is on the Heart and Stroke Foundation of Canada's Canadian Stroke Best Practice Guidelines Committee. She co-chaired the writing committee for the Cerebral Venous Thrombosis Guidelines and has also contributed to the scientific statement and practice guidelines for the AHA, ASA, and Thrombosis Canada.
And Dr. Jennifer Mandzia, MD, PhD, FRCPC, is a stroke neurologist and associate professor in the Department of Clinical Neurosciences at Western University. She's a medical director of the Southwestern Ontario Stroke Network and London Health Sciences Centre Stroke Program. She completed her neurology residency at Western University in 2012, followed by a one-year stroke fellowship at the University of Calgary Stroke Program. With Dr. Thalia Field, she is the co-chair of the inaugural Canadian Stroke Best Practice Recommendations on Cerebral Vein Thrombosis, recently published in 2024. Thank you both for participating in our podcast today.
Thank you for having us.
Thank you. Great. So let's start with an easy question. Why did the group decide to develop this new module on cerebral vein thrombosis?
Well, it's a rare type of stroke, but we all see it often enough that there are lots of unanswered questions in our day-to-day practice, I think, with cerebral venous thrombosis. There had not been a dedicated Canadian best practice guidelines for this type of stroke specifically. And at the time that we started, other guidelines that people were referring to, like the European Stroke Organization guidelines and the AHA scientific statement, were out of date and hadn't taken into account use of DOACs, which was, I think, an important question that was coming up frequently in clinical practice. But I think there were a lot of other unanswered questions that we thought, even if there are not clear answers, were worth bringing to people's attention and discussing available evidence and pointing things out as knowledge gaps and need for future research. And then the last thing I'll say that's really nice about the Canadian Best Practice Guidelines Initiative is that they have a patient consultation committee. So it was really the first guidelines where we had the opportunity to consult with patients on what their priorities were for guidelines for cerebral venous thrombosis, which I thought were really, really helpful for us.
This is great. So I think it would be useful for the audience to know what are the risk factors for CVT and how does it present?
So CVT, as Thalia was saying, is a more rare form in the stroke type of diagnosis. And it is, anybody can get a CVT, but is definitely more common in females and definitely more common in females under 50, right? There's about an 8-fold increase in women under 50 with CVT. And so specifically around oral contraceptive use. So that increases the risk of CVT. Even though it is a rare disease, it still does increase the risk of CVT. So there is an 8-fold increase with that. So often women can be misdiagnosed, meaning a diagnosis is missed in these types of women because they're younger, they're presenting with non-specific symptoms. So in terms of the most common symptoms, it's a headache, and sometimes it's confused for migraine, for instance. So people will come in and they will complain that they're having a headache, but they will say this is different than my migraine, right? But because the symptoms are rather non-specific, it can sometimes be missed. So it's really important that physicians have a high degree of suspicion in patients presenting with a different type of headache, who are younger, who are on the OCP. As OCP is a risk, also pregnancy is a risk, and the peripurium phase is also a risk, and anybody on hormone replacement. But women are definitely more at risk having CVT. The other types of presentation can be seizures, visual disturbance, and sometimes it's very non-specific, meaning my vision is blurry, not necessarily loss of vision, but they may be presenting with visual disturbance, which could be a sign of increased intracranial pressure. And sometimes they can present with stroke-like symptoms, so focal types of neurologic symptoms. And in very severe cases, they can present with loss of awareness or loss of consciousness. And because of this, it's not always an acute presentation. It can be rather insidious, which makes the diagnosis challenging. So, one of our key messages that, providers have to have a high degree of suspicion and patients presenting with these types of symptoms, especially in younger women as well.
Right.
Yeah.
In your paper, there's a wonderful diagram, figure 1 in particular, showing all these risk factors, and it attracted my attention, the pregnancy and postpartum. What are the risks? I'm curious to know what are the risks in pregnancy and postpartum here?
So it's actually about as common as other types of pregnancy-associated strokes. So our colleague Rick Swartz and Patrice Lindsay, who is one of our co-authors on the guidelines, did a nice review a couple of years ago of the pregnancy-associated stroke literature. And I think the prevalence of CVT was 9 per 100,000 pregnancies, whereas just for ischemic stroke and intracerebral hemorrhage, it was like 11 or 12. So it's pretty similar there. The thing is, though, the increased risk of CVT is primarily in the postpartum period, in the first 6 to 12 weeks. That's when the risk tends to be most elevated, as opposed to during pregnancy itself.
Right. Thank you for that.
So if there is suspicion for CVT, how should it be worked up? Specifically, if you could comment on the utility of D-dimer and which imaging modalities are recommended.
So, someone presenting with this really severe headache and a suspicion of CVT, just to address the most appropriate imaging modality. So a plain CT or just a CT head without vascular imaging is not helpful. Okay, we do not recommend that. We recommend both parenchymals. So what we would mean by that is imaging of the brain and the structures of the brain, as well as vascular imaging. From a access and simplicity point of view, CT venogram, so that's a CT with contrast, that's going to look at the venous system, look at the venous sinuses, and that will also visualize the cortical veins, is a easily accessible technique to use in a patient presenting to the emergency department. So that would be a recommendation. If you can get an MRI of the head or an MR venogram, which is also an alternative technique to use. Specifically, we would want the MRI to have contrast for better visualizations of the veins. That is also appropriate. But from an ease of access, a CT venogram is probably the easiest test to get. And that would be our recommendation. In terms of D-dimer, so it has been explored as a screening tool, mostly as, should it be a screening tool to identify the patient who should go on to have further neuroimaging. Just because it's so non-specific, the findings, our recommendation is the evidence is not great as it is in DVT. So there has been a systematic review and meta-analysis which did look at this question for suspected CVT. And, with an elevated D-dimer, the sensitivity was around 89%, and and it varied between how long a patient may have had the symptoms and how they were presenting. So it's not, I would say, a recommendation at this point. I think the evidence also is not great, as it hasn't been tested, in a randomized control type of fashion, but the cutoff was, 500 at least in one study, and the sensitivity was around 89% to 64%. So I think it's just not as useful compared to like someone presenting with a PE or a DVT, where the symptoms are a bit more specific, right? They're presenting with symptoms that are more like swelling in the calf. And Thalia has something to add. to that.
Yeah. What I would add, I mean, just basically with the existing literature, it's clear that the patients that tend to have the most elevated D-dimer are those with a large clot burden and those presenting early. So it doesn't really help us as much with the borderline cases where like there's just kind of like mild symptoms, which may be associated with increased intracranial pressure, or people who are having kind of a late or atypical presentation, where it really would be, I think, more helpful in helping distinguish who does and who doesn't need neuroimaging. In some low resource environments where CT, contrast enhanced CT or MR venography isn't available, there have been some discussions about, can we look at, say, the density of a sinus on a non-contrast CT or something like that? And, that in itself is also not sensitive enough. But I have a feeling that there will be a few studies going forward looking at, say, a combination of non-contrast CT plus D-dimer and something like that. And it's possible that there may be a role for D-dimer in the future in combination with some other modalities, but at present, like Jen was saying, I think the evidence is just not strong enough.
So perhaps we can now move to management. The guidelines recommend low molecular weight heparin over unfractionated heparin as an acute management. Could you please comment on the benefit of low molecular weight heparin over the unfractionated one, especially with regards to bleeding risk?
So I think this was one lesson that we were so grateful to have learned from our thrombosis colleagues. I think, neurologists tend to be a risk-averse bunch in general. And I think previously there was a real preference towards use of IV unfractionated heparin because we thought, okay, well, if there's bleeding risk, we can stop it and it's reversible. But I think what we really learned from our thrombosis colleagues is about how unreliable the pharmacokinetics are and how much more helpful it is to actually give a dose of an effective anticoagulant as opposed to be trying to chase, someone's PTT that's either too high or too low. I mean, the actual evidence with CVT is not very strong. There were a couple of tiny, unhelpful randomized controlled trials and an analysis of I think prospective observational data. And basically, there may be some trend towards an advantage of low molecular weight heparin in the literature with lower mortality rates, but really it's based on our extrapolation from the other types of thrombosis literature. And I think we've been really happy with kind of fanning it out into practice and having more reliable effects and better pharmacokinetics and better results. I mean, with bleeding risk, and we'll talk about this a little bit more, I mean, I think the higher bleeding risk will be overshooting and having a supertherapeutic PTT as opposed to, an effective treatment that's actually helping the clot recanalize and removing that impetus for the bleeding due to increased hydrostatic pressure in the venous system.
Right. Okay, so talking about bleeding, the guidelines mentioned that 30 to 40% of those with CVT will have a coexisting intracranial hemorrhage. So how does the presence of intracranial hemorrhage affect your anticoagulation management?
So it makes us nervous when we see the hemorrhage, and it is counterintuitive to our practice that why would we want to start someone on an anticoagulant in this setting? So I think it's definitely, the evidence is limited, but as Thalia was saying, the pathophysiology where you have this increased back pressure, which is causing, rupture and pressure to build up and to cause the bleeding, necessitates that you want to treat that. So you do want to treat the clot. It doesn't mean that we're not nervous about this and that we don't evaluate each patient and decide, what we're going to do and that. So as Thalia was saying with, I would say that there is a lot of risk adversity around low molecular weight heparin and unfractionated heparin. We would still recommend treating, and I think we would, in most individuals, want to use low molecular weight heparin. Sometimes there is, in certain circumstances, especially someone who may have a large ICH, for instance, and you're worried that they may need a surgical treatment like a EVD place, so external ventricular drain, or you think this patient is going to need to go for surgery, you may choose unfractionated heparin in that situation because you can easily turn it on and off, but there is still that same concern of undershooting and overshooting. So I think these are the type of patients where you are going to still treat them. You are going to decide on an individual basis what the best management is. And in some situations, these patients may require urgent surgical, decompression for the hemorrhage. So these are really cases and patients where you're going to have a team and talking with thrombosis, talking with neurosurgery, ICU, and stroke neurology on how to manage these patients.
What I would add is just, the 30 to 40% is any type of bleeding in the head. It's, everything from like a little bit of petechial change to kind of larger, more concerning hemorrhages with mass effect. And I'd say in general, kind of the degree of hemorrhage that we see with cerebral venous thrombosis is on that more mild end of the spectrum. I mean, most patients that present have more mild presentations as opposed to the, huge mass effect, depressed level of consciousness, ones that really do cause a lot of anxiety and discussion with co-management. So, I mean, I think in general, for most cases, people can feel confident giving anticoagulation despite the presence of hemorrhage on their scan. But it's always nice to have that joint neurology stroke expertise alongside the thrombosis work so that we can kind of contribute our relevant expertise and decide on things like, follow-up neuroimaging and keeping an eye on that bleeding and things like that.
So, away from anticoagulation that we're talking about right now, we are curious to know if there's a role for endovascular therapy or things like decompressive hemicraniotomy in the acute phase.
Thalia, do you want to take the endovascular therapy and I can answer the decompressive hemicraniotomy?
Oh, sure. Give me the easy one, right? So, endovascular therapy has really revolutionized acute ischemic stroke treatment in the last several years. And I think, there really is an interest as to whether or not endovascular therapy would be helpful for patients with cerebral venous thrombosis. But I think really there are so many unanswered questions with regards to who's an optimal candidate. I mean, the fact remains that most patients with cerebral venous thrombosis have, on the spectrum of all types of stroke, a good functional outcome where, over 90% in many cases will end up being functionally independent. And, up to like 60 to 70%, even at the time that they present, are functionally independent. So kind of the risk-benefit calculus is a little bit different. There aren't catheters that are designed specifically for the deep venous system, and same thing for the venous sinuses. So you're trying to kind of use a combination of techniques that are not really designed for the type of process that you're treating. And, we did an international survey recently, and like patterns of practice are all over the place. So currently, I think everybody agrees that it is reasonable to use endovascular therapy as a rescue where kind of people are deteriorating despite best medical treatment. But exactly when you would go in and exactly what your threshold is for clinical deterioration, I think is broad. I think we would all agree that people who are I think more experienced with endovascular therapy and or at least can easily connect with someone to kind of watch them and advise them throughout the procedure is an important thing. But I'd say in general, for the vast majority of patients, medical therapy is the standard of care, and most people will have a good outcome with that. There was a randomized trial a couple of years ago, but it was stopped early for futility. And I think the other question that just remains is like, what kind of outcome do we use for an endovascular treatment trial in cerebral venous thrombosis, given that a lot of people end up functionally independent, and kind of at what point we assess that. So it's an area of controversy. We use it for the sickest patients, but beyond that, I can't give you a straight answer.
And in terms of decompressive hemicraniotomy, and for your listeners, which may not be as familiar, this is basically going in, opening the brain and the skull and letting it swell, right? So, I'd say we have much better evidence for this in acute ischemic stroke, and that there's been less studies and maybe in CVT compared to ischemic stroke. This is typically reserved for the sickest patients, and it's a life-saving procedure. So the procedure is done, and it has to be done when you discuss it with the family in terms of, is this within their goals of care? Because it is a life-saving procedure. It might not change their disability necessarily. There is one study, probably the largest study, the Decompress 2 trial, and that's the largest to date. The rates of deaf and functional dependence were higher than we expected. So it's something that you're going to do. It's going to be a life-saving procedure. And in most of CVT patients do well, but this is one of the procedures that would be offered if someone is very, very sick.
Okay. So in the acute phase, we discussed using low blood heparin. Is there a point where we can switch to oral anticoagulation? And what is the data for DOAC use in CVT?
So, most patients who are admitted to hospital are going to go through a period where they're on parenteral anticoagulation. I mean, I would say kind of as a general rule, when you're no longer biting your nails about how frequently you need to reimage and reassess the patient clinically, I think that's a good point for switching people to oral anticoagulation. So basically when patients are stable. I mean, there certainly are patients who present to emerge who are mildly affected, who have kind of isolated intracranial pressure, and who, are able to reliably follow up with you for repeat clinical assessment and neuroimaging later in that week. And I would say those sorts of patients where you don't think that they need admission otherwise, those are patients where I feel comfortable putting them on a DOAC, assuming that they're otherwise appropriate, not pregnant or breastfeeding, don't have antiphospholipid antibody syndrome, didn't have like a recurrent event while they were on a DOAC or something like that. But, that aside, those are the sort of patients where I would feel comfortable putting them on an oral agent and bringing them in for subsequent follow-up in short order. As for the data for DOAC use in CVT in general, our knowledge has really increased dramatically over the last several years. There were several smaller randomized trials, including one that we ran in Canada, the SECRET trial. And more recently, there was a very large retrospective study of DOAC use in routine clinical practice compared to warfarin use in routine clinical practice called Action CVT. And then the results of kind of a companion prospective registry called DOAC CVT, the results were recently announced at the World Stroke Congress just last month. And the results are still pending publication. But basically what it shows is that for patients who are more mildly affected, who aren't comatose, who don't have very, very severe presentations, and don't have kind of controversial area for DOACs like antiphospholipid antibody syndrome or cancer, things like that. Those patients in general seem to be okay with DOAC as a reasonable alternative to warfarin. The randomized trials were really too small to show any difference in efficacy or any significant difference in safety that kind of push you to one side more than the other. Action CVT had 800 patients in general. Again, it's retrospective, so there can be some confounding by indication, but they did show a relative risk reduction of about 50% for intracranial hemorrhage for DOACs over warfarin, similar to what we see in other trials. The DOAC CVT study did not show that same relative risk reduction based on the results that we currently have. But what's interesting is that the predominant agent that people were using in Action CVT were factor Xa inhibitors, specifically apixaban was most popular. Whereas in DOAC CVT, the agent of choice has been dabigatran at the 150 BID dose generally. So whether that may have anything to do with it, it's really hard to know. But again, overall, in general, for your average patient who is coming in appropriate for oral anticoagulation, DOAC is reasonable in most cases, I would say.
Well, great information on anticoagulation. I think we have one question also on the anticoagulation. What about the duration of time? How long should we be doing this for a CVT patient?
Another very easy question. So, it's interesting if you look at patterns of practice. So kind of the recommended duration of treatment, if you look at the CVT guidelines kind of all over the place, is somewhere between 6 to 12 months for your average patient. And you can kind of move that closer to 3 months for your very clearly provoked event, and the provoking event like OCP is off or something like that. But it's What I would say in general is how long the duration is depends on kind of the risk and if you're transitioning that patient into indefinite anticoagulation. And I was very heartened to learn at the recent Thrombosis Canada conference that this is a question that even you guys struggle with for indefinite anticoagulation in some cases. But in general, for recurrence, the lower risk cases are those provoked cases isolated to OCP without any other identified kind of lingering thrombophilia, whereas patients that tend to have higher risks of recurrence that don't have a known thrombophilia or cancer are unprovoked cases, and those occurring in men and those occurring in older people. So that's kind of the spectrum of risk. With regard to like kind of treating the CVT that is on the scan at that time, I'd say most neurologists in Canada, at least, are practicing where they're anticoagulating between 6 to 12 months with repeat neuroimaging just to kind of push them towards 12 months versus 6 months in terms of whether there's recanalization. But what we're learning, which is really interesting, is something that we've only kind of become aware of in the last few years, is that kind of after the 3-month point, there are diminishing returns and with respect to increasing recanalization. Most people will have done as much recanalization as they're going to do by the 3-month mark. So I'd say once you get to 6 months, it really depends on how the patient is doing. Are they having issues, say, with heavy menstrual bleeding or contact sports or things like that? And I think by 6 months, you can comfortably make the decision based on the patient's risk stratification and this, joint decision making, which is, kind of our overall term that seems to help that time point in thrombosis decision making.
Yeah, I'd like to stress the importance of co-managing these patients, which I do with thrombosis. So I really do rely heavily on my thrombosis guide, my partners, and at minimum, 3 months is probably the minimum that we would do. Sometimes, as Thalia was saying, like the imaging doesn't necessarily correlate with your decision making, or it shouldn't, and that's maybe a point to think about. A lot of the time, most of the changes in imaging are going to occur early, and it doesn't necessarily factor in how long I'm going to continue to anticoagulate someone. But I really think one thing from the guidelines we really want to communicate is the importance, given that this is a rare disease, of co-managing, right, these patients with various specialties and with the patient.
Great, that's very helpful. So a specific type of CVT we sometimes come across as secondary to trauma. Could you comment on how management of trauma-associated CVT is different from standard?
So again, probably this is becoming much more common that we're identifying these patients, because many patients now who have a head trauma often get a CT angiogram where you can still see the sinuses, right? The venous sinuses. And often this is coming up, right? So there's definitely a higher pickup rate for this. Again, it's going to be on a case-by-case basis, working with the team when to anticoagulate the patient or if they need anticoagulation. So I would say, if they have major head trauma and there's acute bleeding, there's no signs of complications from the CVT, being that the hemorrhage per se is a hemorrhage related to the CVT, or that there's an ischemic stroke related to the CVT. So that would probably sway me against anticoagulating right away. And you may not anticoagulate. Once their trauma is stabilized, then you would probably re-image them and make a decision around anticoagulation in that. So you have to kind of weigh the risks and benefits. Because often these patients not only have head trauma, they may also have trauma in their body or other fractures, or may need surgery. So it's very complicated, but I can't give you a yes, no. It's going to be a case-by-case basis decision.
Yeah, I mean, and I think it's a question that we struggle with, but in general, patients that have trauma-associated CVT also have a skull fracture, and so they're probably going to have a traumatic brain injury or subdurals along with that. So it's kind of easy for us to say that it's not safe to anticoagulate at that point. But, in general, I think, repeat clinical assessment if the person is in comatose, and repeat neuroimaging is very important. And yeah, if the CVT is not extending and it's not causing injury in and of itself, like a venous infarct, I think you can feel more comfortable treating conservatively and just say starting, indicated DVT prophylaxis when is needed, or, aspirin if the patient has a blunt arterial cerebrovascular injury, or whatever else you need to do. The few case series in the literature, I was quite surprised to find that they were kind of making a point that there is a lot of secondary injury due to the cerebral venous thrombosis. I would say it's not what we see in our clinical practice. And I really do wonder in some of these cases if they're mixing up kind of injury from the traumatic brain injury with the CVT in and of itself. But, it's small case series, they're retrospective, and we really do need better literature.
This is great. Well, the guidelines are very thorough, and we covered a lot of items. I just want to ask if there was anything that we missed or anything in particular you want to highlight in addition to our discussion earlier.
So I would echo Jen. I think the the co-management and expertise for a disease that spans so many different disciplines is really critical. One thing that didn't come up is we've recommended that ophthalmology get routinely involved just to check for papilledema. And there are cases where I think it really is a difference in initiating management for increased intracranial pressure, like acetazolamide or not, that can help preserve someone's sight. And people also need ongoing ophthalmology follow-up. So that's one thing I would add. And then the second thing is just, as neurologists, we never really thought about heavy menstrual bleeding as a complication of anticoagulation. But I mean, in general, these are young women, and it's really something that we need to think about, counsel about, ask about. And again, I think our thrombosis colleagues have really led the way in terms of considering women's issues as it relates to anticoagulation. So those would be my big things. Jen, is there anything that I missed?
The other thing is patients who do have CVT, even though the clot may be gone or the sinus has recanalized, they still can have chronic complications. Headaches are very common. Even though their brain has not shown a stroke or a hemorrhage, there's something going on in the brain that we can't see on our imaging. So it's really important to screen for depression, cognition, return to work, return to driving, return to, this life, relationships and that. And especially it's a young population. So it's a different population than maybe our typical stroke patient. And, even though they may have had a minor stroke or a minor event, those can still leave people with significant disability. So I think that's really important to communicate, because that can really affect people's quality of life.
Right. Well, thank you very much.
Thank you.
Thanks.
Thank you all for this great discussion, and thanks to our audience for joining us on Clot Conversations. We love hearing from you, so send your comments, questions, and ideas for future episodes to info@thrombosiscanada.ca. Want to stay up to date on the latest in thrombosis? Hit the subscribe button so that you never miss an episode. And don't forget to visit thrombosiscanada.ca for a wealth of resources, including clinical tools, patient guides, and information on our annual conference. Your support matters. Consider donating to Thrombosis Canada to help us continue the fight against thrombosis.